long 6 months or so since April 1 when our grant year started, and we really were operating with partial information. But from the end of August through the end of September, we basically got all of our specific funding pots confirmed. And I'll just put this up here to show how sort of fragmented the grant has become. Years ago, we had Part B base and ADAP earmarked, some $8 million, and then over the years, it's just sort of continued to expand, and each one of these funding sources typically have their own reporting requirements and have to be tracked separately. But we did get confirmation of our Part B base, our Part B supplemental, which is that competitive component of the Part B award, ADAP earmark, ADAP supplemental, ADAP emergency relief funds, minority AIDS initiative dollars, and emerging community dollars. And just a quick reference as to sort of what the final outcome was. You can see we got a small increase in our Part B base of about $228,000. Our ADAP earmark, we were very pleased to see that it went up $1 million. And we were extremely pleased to see that our ADAP emergency relief funds came in at level funding. And as you remember, there was quite a bit of discussion earlier this year when HRSA came out and said the maximum any state could receive was $3 million. And there was a lot of inquiries from the political arena and advocates, et cetera, and HRSA altered their policy to allow states to receive up to what they received the previous year. So we were fortunate to get that $6.9 million, so there was no change there. ADAP supplemental, this was the first year that we qualified for that, came in at $6.6 million. We received a small increase in MAI funds. Now the Part B supplemental, we did take $1 million cut, but those dollars basically are available from an expanded carryover. It's sort of a catch-all funding pot, and as you would expect, funding tightens nationally. States are more efficient at spending their dollars, and there's not as much of that funds that come back unspent. So that was sort of intuitive that we probably would take a cut there, but still received over $1 million. And we received a reduction to the EC award. But overall, if you compare year to year, we were up $6.6 million, which I think was great, really better than I initially was hoping. Looking at the Part A side, we did a quick analysis there, and generally the news there wasn't as positive overall. If you look at the state as a whole, it went down by a little over $1 million, but there were a couple of EMAs that received small increases. But that's still $73 million coming in on the Part A side for services. Just specifically focusing on ADAP to sort of look and see what are our resources for ADAP services for the remainder of this year. Of course, the ADAP earmark of $86.2 million, the ADAP supplemental $6.6 million. We dedicated all of the Part B supplemental to ADAP, as well as the emergency relief funding. From the general revenue side, we were level funded at $9.5 million, but the Bureau and the department made a decision to reallocate $1 million GR funding to ADAP services. So for this year, there's actually a total of $10.5 million for services. So that's up $1 million from the previous year. Now, coming into where we are now with ADAP services, we now have approximately 9,100 people in the program receiving services. We're in the process of enrolling 1,500 persons from the waiting list, and we have about 3,300 people on the wait list, and that is down from a high of almost 4,200 in September, early September. September 1, 2011, the CVS Caremark Pharmacy Benefits Management Contract came into place, and that was designed to service the Medicare Part D patients who are on the ADAP program. And that is up and running, and we have over 500 people being managed and receiving services through the CVS Caremark network. And this was very important because it allowed for the real-time sharing of expenditure information related to TROOP and getting that information real-time to CMS where it can be tracked and allow the Medicare Part lead patient to actually get into catastrophic coverage just as quickly as possible, where the out-of-pocket expenses are under $10 typically per prescription. And based on this new funding, I think one thing that we just need to keep saying is that ADAP will be able to serve all enrolled clients for this remainder of this year. There will not be a structural deficit in the program. There will not be a shortfall where existing clients will be threatened with interruption of therapy. So that's something that we want to reassure people that the program is solvent and will continue through this year with no interruptions for people being served in the program. And we will continue to monitor program expenditures and authorize additional enrollments as analysis permits. And one thing, since we know what our funding is, you know, we were in the wait list mode for so long and unable to bring people on because for 6 months we didn't know what our funding was. But now that we do know, I think we'll be seeing people routinely come into the program as people attrition out. So there won't be these months and months and months of no movement into the program. And from a technical perspective, from a data management perspective, the ADAP data is being imported into CareWare. And Rich is going to talk about that a little bit more when he speaks, and sort of highlights that CareWare continues to be sort of the core system that we're building around. And when I was here last, we were sort of in the middle of the Well Vista transition and partnership, where they were serving about 60% of our folks for 2 months essentially. Just wanted to sort of recap what was going on with that. As you remember, we did project that there would be a structural deficit and we wouldn't be able to sustain all the ADAP clients through the 2010-2011 year. In February, the Bureau and the Department entered into an agreement with Well Vista to take on about 60% of the ADAP clients for approximately 2 months. And ultimately 5,403 persons were transitioned over and received their therapies from Well Vista through March 31st. And then sort of the tally of the outcome of that, and I've already shared that 5,403 people were served, but 10,267 prescriptions were provided at a cost of $23.8 million. So that was sort of the bottom line of that program. Looking at insurance services, just to reiterate that insurance is now sort of a component of the ADAP program. And the reason that we continue to talk about that is that to be able to request rebates on copay and deductibles that are paid for people with insurance, the people have to be, quote, ADAP clients, or we're not able to request that additional revenue. So pretty much insurance clients are now a component of ADAP, and that does allow us to request copays and deductibles to be used as rebates, to request rebates. And we're in the process of amending the AICP contract with $3.7 million, which will actually clear the existing waiting list of about 362 people, and we project that we'll be able to sustain open enrollment for the remainder of the contract year. And we're also able to open up special services where people can get additional assistance with copays and deductibles, because that was one component of the program that was frozen quite a while ago. Because you remember, we've had a wait list for AICP services since July 2009, I believe. So that's quite a bit of good news, I think, there. Yes, sir.
Do you have an estimated time that you think that you're going to be able to clear that wait list and the time to start copays for those local parties that are covering those services currently?
To try and transition the people.
Yeah.
The amendment is in progress. We're hoping for an execution date as early as November 15th. And we've talked with Robert Sandrock and the Health Council, and they have already prepped letters to the agencies which are handling the waitlist clients. So he said he's got everything pretty much done, short of having the monies added to the contract. So as soon as the execution occurs, he said he'll get those letters out and immediately start the transfer of people into the program. And another sort of data aside is that the Health Council of South Florida, who administers AICP, is also entering their data into CareWare. So So those were two large programs that have not been fully integrated into the CareWorks system, which is now underway. Some other general comments. I know everyone's been interested in the eligibility rule and where we are with that. In April and May, probably many of y'all know, we had 4 public workshops around the state. We had 2 in Miami, 1 in Tampa, and 1 in Tallahassee. And the very strong take-home message from that is that there was a very loud recommendation: do not change eligibility from the current 40%. I think everyone felt that any reduction really was unacceptable from that point, and that is that feedback has been heard and has been reviewed by the department. So I think the reason we had the meetings really came through strong in elaborating on that. We've actually got all the proposed technical corrections and enhancements to the rule ready. You know, we were changing references to Title II to Part B. We were having to mention the program qualifications for our main programs because ADAP, we need to have a prescription of our letter. All that information is in there. We've been in a holding pattern because there hadn't been a final decision made regarding the financial criteria. And one of the main reasons for that is that leadership wanted to know, well, how much money we were going to have to work with. And since we've received that in the last month or so, I expect that a final decision will be made in the next several weeks. And as soon as we know something, we'll share that with you all, and I expect the rule amendment process to restart at that point. Comments on the HRSA site visit report. As you remember, that came out in March, and we've been working with HRSA constantly since then, and actually now have a series of bi-weekly calls with our project officer to talk about activities related to that. Basically, the timeline as far as the action plan was, we were asked to submit a draft plan in July, which we did, and basically addressing just each of those recommendations that HRSA gave us. We received feedback from HRSA in September, and they asked for some changes, and we made them and resubmitted the draft document this month. And they are still reviewing it at this point, and to sort of spur the dialogue and discussion, we're now having bi-weekly calls with our project officer to talk about specific activities and just to keep them apprised as to what's going on. I expect that we will finalize the plan soon, and then we will have a document that has been completely blessed by HRSA, and that we can say this is the final activity plans related to the report. But you know, many of the recommendations were in progress when the report came out, and we can say that several of them are complete. The pharmacy benefits manager is complete. We are now requesting rebates on insurance copays and deductibles. Some of the administrative recommendations have been completely implemented. Some of the larger system changes is where we're trying to really say what makes sense. Do we need to do additional research? We have requested technical assistance from HRSA on several sort of complex issues. One is data integration and management. The second was just looking at our insurance rebate request process. And the third was related to quality management. Now, unfortunately, HRSA has placed a freeze on technical assistance. But we are looking at exploring other opportunities through the National Alliance of State and Territorial AIDS Directors to get some technical assistance on site sooner than later. So I think we can still come up with some content experts to come down and look and give us their feedback. Also, you may be aware that in June, the department was replaced on restricted drawdown for Rhineland Part B funds. And this was because primarily we have an ADAP waiting list, and as it has been explained to us, states with wait lists have been placed on drawdown restrictions. And I think HRSA's intent is just to see, are there expenditures being made, or are there things that could be changed that would significantly free up resources for waitlist services. And we've worked with our project officer monthly. She's saying she really hasn't found anything, any recommendations of any degree that would help with that. But we continue to provide whatever is requested. And the discussion is now that if things continue to go well, she's looking at December, talking about transitioning us off job instructions, and we'll go back to more business as usual. So I think her analysis is going pretty well, and we continue to work to, provide whatever documentation she requests. Another big deal is the DOH reorganization, and I really would like Tom Liberty to speak to this because I always think he's got a more global perspective, but I will sort of tell you what I know about that at this point. A couple of weeks ago, a draft table of organization was released, but it really just went down to the division and bureau level, so it didn't give any sort of rubber hits the road content as to what will our programs look like, et cetera. But I think one of the main goals is to reduce the number of divisions and bureaus in the department. The number of divisions would go to 11, from 11 to 8. The Division of Disease Control, which houses the Bureau of HIV/AIDS, immunization, TB, I think 5 bureaus in total, would become the Division of Disease Control and Health Protection. And the Bureau of HIV/AIDS would go away, and its functions would be incorporated under one Bureau of Communicable Disease under Communicable Disease Prevention. And looking at the different titles of the different bureaus and such, I'm not sure exactly what all it means, because there's when you talk about disease prevention, there's another one that talks about chronic disease, and I was just thinking, well, maybe it would make more sense for the bureau to be under chronic disease. But those are the type of details that haven't really shared with us yet. But the TO does place us there in the new Bureau of Communicable Disease. Many details are still left to be confirmed, and a lot of blanks filled in. But importantly, or most importantly, a number of activities related to the reorg would take legislative action. So if the legislature doesn't approve and vote for the necessary legal changes, we can't implement a lot of this because it's actually in law, some of the current structure of the department. So I think a lot to come on that, and with the session I think now running through March, it could easily be March or April before we know exactly what all this means for our program. Some other activities, I know our lead agencies are aware of this, but the contracts would typically start in April 1st, have been extended for 3 months through June. A lot of this is timing with some of these sort of unknowns that I've mentioned already, but typically by now we provide templates, we give instructions for contract negotiations to begin at this point, and we just felt like we didn't have enough answers to really give that guidance to know exactly what's going to happen, for the next full contract year. So what we did to give us some additional time for planning and execution is to say, let's extend these contracts 3 months, and I think we'll know a lot more than we do now. So the contracts that we have, the plan is to extend them through June and have new contracts starting July 1, 2012. And there's some discussion about aligning or incorporating some of our patient care network contracts, the general revenue contracts, possibly into one contract in areas that now have one for GR and one for non-white. But that's just being looked at. The thought was there may be some administrative efficiencies in doing that, but no final decision has been made. Another significant change is Spencer introduced himself with the AIDS Institute. He did retire recently. And we have a new senior epidemiologist in the Bureau. And I would like to introduce Kate Gooden and just allow her a moment to tell you a little bit about herself.
Hello everyone. Thanks for the welcome, and I really look forward to working with all of you. I've only been in the Bureau of HIV for about 2 weeks now, so I'm really brand spanking new. But I was with the health department previously in the Bureau of Epidemiology, and I've been there for 4 years here at Cleveland. So I really look forward to meeting all of you, getting to know you, and then working with you. So thanks.
Thank you. And then, of course, this time of year, our Part B grant, it's sort of, it's off kilter because we just got our grant award, but actually we just got our grant guidance to start our application process for 2012. So we're now jumping into that, and we have a due date of January 3rd, 2012 for that. And for the next 3 or 4 weeks, we're going to be working pretty much full out on our application. A lot of it hasn't changed, but some of it has, and but we'll get it done and do a good job on that, and get all the monies that we can for Florida. That is just sort of a brief update. As I said, I think Tom will be joining us shortly, and I really would like him to talk more about some of the topics such as reorg, but I guess at this point, if you have any questions related to any.
Bubba, can you come to the microphone, please?
Okay, with the consortium contracts being extended for 3 months, does that affect the end date of the contracts for the following year? Is it going into March or is it going into June the following year or June?
I think that will decide if there's any linkage or consolidation of the general revenue contracts. There could be, but at this point I don't know. There hasn't been a final decision made, but that's a question that's already been asked.
So what's in the guidance? I mean, what end date is in the guidance?
Well, see, we haven't issued it yet. See, what we've done is just extended the contract for 3 months because we didn't feel like we had all the information needed to issue our traditional guidance. But it will be issued, I guess. Ken, what would our revised timeline for the contractual instructions?
We have ready this out no later than January or the July 1st, 2012.
And so for subcontractors to the lead agencies, that means their contracts get extended or can they be negotiated?
Yes, and my assumption is that most would just extend until then.
What is the status of the possible competitive bidding process in the future for Port Louis?
The lead agency.
Lead agency, right.
That is certainly a topic of discussion right now. As many of you know, the department, the Surgeon General basically said that he wanted competitive processes to be used whenever possible. In the past we used a health exemption, which allowed us for lead agency services to use this exemption, which sort of took us out of the competitive process. The interpretation was that because the lead agency services were not clinical for the most part, that there was a suggestion, well, you need to look at that again, and we're not so certain that the HPM exemption is appropriate. And so there was quite a bit of discussion within the department. There are pros and cons on both sides, but basically no final decision has been made about that, and that wasn't a primary reason for the contract extension, but that was just an example of a big deal that we didn't have any answer for. So no final decision has been made yet.
Would that decision come from the governor's office? That's not our, is it the Bureau's decision to make as to whether or not we do that? Or that's the...
Well, actually, it's the Surgeon General, it's the executive staff of the department, and I'm sure they're in consultation with the governor's staff or whoever they need to be, but it would come from Surgeon General.
They have to
Surgeon
make
General.
it.
Yes, yes. And we will, do whatever they instruct us to.
Debbie, can you repeat what Debbie just asked?
Oh, I just asked, who makes that decision? That's the Surgeon General's office that's gonna make that decision, and then when they make it, then the Bureau will put out, if we're gonna do an ITN or an RFP or anything like that. That was my understanding.
Is there a time frame? Is there a deadline for them to give that to you, Joe?
Well, like I said, we're gonna have to know something, even extending the contracts 3 months. I mean, we're looking at a matter of weeks that we would need to know if you had to do a competitive process. That's time consuming, so we have to know something soon.
David?
Actually, I have a couple questions for you, Joe. The first one has to do with So it's based on new funding, ADAP will be able to service existing clients enroll an additional 1,500 applicants. How many clients were able to be enrolled due to the savings of True? You know, obviously we have clients that are now not paying for an entire year worth of ADAP drugs.
Right. Right now, we haven't used those savings per se to enroll people. We're still analyzing and making sure that the dollars are there. Because, you know, there have been some hiccups with, what's the name of the group, the company that actually, the information like for expenditures have been transmitted to this fiduciary agent, I don't know what else to call it, but there have been some snags with some of the dollars actually getting to the insurance plans, the Part D plans, and some of the people have not gone into catastrophic coverage as quickly as we thought, even though technically we've got the dollars spent. But we've talked with HRSA about this, who's talked with CMS, and we've raised it to a high level, but we haven't gotten complete satisfaction in making sure all those expenditures have moved people to catastrophic. So we're still working with that, but we still expect overall, significant savings. I think a minimum of $1 million that will allow us to serve additional people. But we don't have the cash on hand yet to really bring people in specifically for that savings, but more to come on that.
The second question has to do with, and Ken can back me up on this, I think, on several calls, when we were talking about the ADAP crisis, we discussed the possibility of using PCIP as a way to alleviate that.
Right.
Is that still being considered? And I think it still should be, considering that.
It is. Our priority was to make sure the AICP waitlist was cleared. It's taking about $4 million to do that. We wanted to get some movement on ADAP quickly, but I do expect PCIP to be a component of the solution, one of the solutions to the crisis. But we have not initiated a pilot project yet. But we've been in discussions with the Health Council to be that fiscal agent, to sort of have the capacity to do that. But we're wanting to get the wait list clear to get people with insurance who are needing assistance now served, and that would be sort of the next step in that sequence.
Well, we didn't wait for permission down to the keys, we usually don't. But we currently have 20 people enrolled in PCIPs.
Right.
With an average of $176 for 20-something to $550 a month for a 55-year-old with multiple comorbidities. So when you talk about what you're paying in premiums versus what you're paying out in drug costs, plus they get all their drugs covered, plus because they have insurance, you're no longer using Ryan White dollars to pay for other medical needs.
Right. No, you're right, and it is part of the solution. I have no doubt of that.
We'll stay on.
Okay.
Joey?
I'd like to make a request that the minutes from the ADAP work group be shared with this group, as well as any upcoming conference calls. It's been a little difficult to get information. I usually take anywhere from 5 to 10 emails to find out when is an ADAP call, what is the call-in number. I'm trying to get copies of minutes. It's government sunshine, so that should be readily available for the other work groups so that we know what they discussed, what their decisions were. I think that we could have probably averted some difficulties in South Florida had we known that Complera, the complying product, was not on the ADAP formulary, even though the individual components were on the formulary. So we had some wait list snags with people that were denied access to ADAP because they had Complera prescriptions when the individual agents were on there.
Right.
And so had we known that the ADAP work group hadn't added it yet, we could have avoided some of this.
Okay. We can.
You put that in the form of a motion? Did I hear you put that in the form of a motion, Joey?
Well, I didn't know if we needed to make it a formal motion, but if so, I'll so moved, if that's what we need to do.
Yeah, I want it.
You want it in the form of a motion or?
So that it gets in the official minute.
Okay, so.
Okay, you made that motion, anybody second?
Second.
Seconded by Warren. Any discussion? Okay.
Well, I just have a comment to Joey. Why would your physicians be prescribing a drug that's not on the formulary? Why would you have denials? It's it's not on the
Because
formulary, it should be made.
one of the non-FDA prescription patterns that are happening for people that are on a tripla that have extensive CNS side effects, it's the #1 move for people that can't tolerate a tripla that started a tripla only a month or 2 or 3 ago. So they are still technically sort of naive, but if they're having side effect problems or with RAID has contraindications, it's very easy to move them to Proclaro. So they locked that out instead of letting it be on the formulary, and it's even cheaper at PHS pricing in the single tablet regimen as opposed to individual components. So it's even a cost savings if you look at it that way. So I don't know what happened on the work group.
Well, I can tell you, because there was an email that went out to the work group that said, right now, there's no cost difference. When the drug first hit the market, it was cost neutral. And a vote was taken of the members, I don't know what the tally was, but the decision came back from Dr. Beal sent a reply out saying that until we can sort of work through the fair pricing coalition and see what, bottom line's gonna be, the drugs are available, separately, until we sort of find that out. In about 2 to, I wanna say no more than 3 weeks ago, we had another, email from Dr. Beal saying, it looks like that we need to go ahead and do this, and it was done at that point in time, but it wasn't approved until about 2.5, 3 weeks ago, and I see Mitchell nodding, so. I was just curious as to why.
But again, had the rest of the groups known what was going on, we might have been able to give you some.
But Joey, in the past, has the ADAP work group or that department not notified people when drugs were added to the formulary? You just assumed that the drug was added to the formulary, is that correct?
If it was price neutral, absolutely. Antiretrovirals and reduced pill burdens, if they were price neutral, were automatically added. There was no wait.
Well, that did not happen, so that may be, new medical director, new ADAP program director, since that period of time, but, this is really the first new drug other than Marivaroc, I think, was the first one that came on shortly after I got on the work group. But this is the first, new sort of formulated drug of existing drugs that were out there, and, being unfamiliar with how it had happened in the past, I'm sure that's exactly what happened. Nobody involved in that history or shared that history.
All the more important to keep all of us in communication when snags like that happen.
On the pharmaceutical list, we enrolled about something. Don't we have a right, the doctor have a right to not overrule, but to override in special exceptions or things for people who, in other words, if there's a drug you need that's not on the pharmaceutical, they can determine if that particular person needs that drug or not, and override whatever it is for that person to get that drug. Does that not go for all of us?
That's a decision by the medical director. That's Dr. Beal's decision.
That's his decision?
Yes.
Okay, that's not for each individual.
It's on a case-by-case basis.
Area, okay, it's by case by case. Okay, thanks.
Any other comments? Yes, Karen?
Joe, this is flipping back to AICP. I heard a rumor that contract is going to be put out for RFP as well. The contract that the Health Council of South Florida has had since the 90s. Is that, can you talk about that?
It's under consideration as all our contracts are
Okay,
being reviewed.
thank you.
We have a motion on the floor, we want to go to that.
Joey, let me just make sure this is, you're requesting that, the ADAP work group meeting minutes be shared with all other statewide work groups. Is that correct? So the motion was made by Joey, Wynn, and seconded by Martin.
And upcoming calls be notified to our listservs as well.
Is there any more discussion on the motion? If not, I'll call for a vote. All in favor of putting that in the minutes and asking for the reports? Signify by standing in your head or saying
Yeah,
aye.
raise your
Raising
hand.
Raise your hand.
One. 19.
Opposed? Carries. Motion carries unanimously.
certainly if Tom joined us, to give him opportunity to share his comments, but I don't believe he's here yet, so.
So Spencer, guess what? Thank you, Joe, very much. So we're going to move on with a presentation from Spencer Lee from the Florida Consortium for HIV/AIDS Research. Spencer, this is the first time you're here, not being FB.
Yes. And, you know, you tried to get rid of me, but
No,
didn't succeed.
we would never do that.
In spite of having 3 farewell parties, courtesy of the AIDS Institute, which in all seriousness has stepped up to the plate in supporting this new initiative for which there's really no paradigm in the country. And in particular, I want to thank Michael Rubel, our executive director, for agreeing to be supportive and house. I shouldn't say, but really an integral part of the AIDS Institute now.
Oh, he's done. Okay.
The Florida Consortium for HIV/AIDS Research comprises 19 research organizations right now. They're shown on this map here. We have 116 HIV researchers, and they account for more than 400 recent and ongoing studies. You've all seen this Christmas tree slide before. I just want to point out some important things because there's a reason why there's so much research being done in this state. We're 4th in the nation in population, but we're 3rd in the nation in cumulative AIDS cases and 2nd in the nation in cumulative pediatric AIDS cases. We have 97,978 persons living with HIV/AIDS through 2010. And as we see in most of the country, there's a great disparity where the population is 60% white up there at the top, 16% black, 20% Hispanic, and 3% in other. But the PLWHAs, whites account for 30%, blacks account for a full 49%, Hispanics for 19%, and 2% in the other category. So the disparity is really quite marked. The prevalence estimate is about 135,000. The incidence estimate for 2006 through 2009 is approximately 5,000 per year. That includes persons who are not aware of their HIV infection. And the deaths due to HIV/AIDS in 2009 is 1,232. That's down from a peak of 4,885 in 1995, the year before the advent of HAART. And I didn't have time to update that last number, but the good news is that deaths have gone down in the previous 2 years consistently, about 13% and 7%, and in 2010 we've dropped another 15%. So that's really good news, and that's happened despite the crisis with ADAP. So the gap in services for ADAP has really been filled in or met by WellVista and the ingenuity, I think, of the Department of Health. The consortium was conceived in the spring of 2010. We had our first meeting in February of 2011, and we had 65 researchers participating, but like I say, we now have 116 members. We formed it mainly for coordination and collaboration, to enhance prevention and treatment strategies, and to make gains. This is about an ambitious mission statement. We want to make gains in developing microbicides, a vaccine, and a cure. We initially began operating under the Florida DOH Bureau of HIV/AIDS with unfunded support from the AIDS Institute. And the consortium needs to be flexible and free of bureaucratic restrictions. I don't know why we have that bullet in there, because there's really nothing bureaucratic about the Department of Health. And the consortium now is formally incorporated in and administered by the AIDS Institute, which, as you know, is a nonprofit agency which is sponsoring this meeting, and it's an entity quite independent of the state. Key dates in the timeline: in the spring of 2010, the consortium was conceived, and it was really the brainchild of several people who met at the HAPC meeting in the spring of 2010. And that was Tom Liberty, Rafik Pierre Sakali. Dr. Sakali is the head of science, director of science at the Vaccine and Gene Therapy Institute, Dr. Jeff Beal, and myself. In February, as I said, we held our first meeting, and in March, we had our first conference call with the membership, and we formed a steering committee at that time. In April, we had a conference call with the steering committee, and we formed 4 working subcommittees, and had our first conference call with each subcommittee in May. In June, we began to follow up with recommendations. We'll get to that. In July, we designed and conducted a survey of hard-to-reach populations and hard-to-obtain biologic specimens. In July 2011, we also began to be administered by the AIDS Institute. In August, we distributed the survey findings from the hard-to-reach survey. In September, we recruited the HIV/AIDS research coordinator out of retirement. And we had the second series of subcommittee conference calls in September. This month, we developed research regions. I'll be showing you the map of that. Even though it's draft, it only shows 3 regions, but we've subsequently decided that 4 regions makes more sense. And the regions are really developed to ensure that we get good collaboration within county, across county, even across regions. And this is going to also help ensure that we reduce duplication of effort. And in line with that, yesterday Michael and I, doing some strategic planning, determined that it would really be good to find out from other states what research is currently going on or what research is being proposed. Because there is a lot of duplication in the country, and although this is an ambitious goal, we'd like to find out whether we can reduce that duplication and lead to more collaboration. We're planning a second annual meeting. We formed the Executive Advisory Board. Actually, we now have an Executive Advisory Board slate of nominees that we're going to send out to the general membership for approval. In November, we hope to procure long-term funding for the consortium. December, we'll have a planning call with the Executive Advisory Board. And in January 2012, we'll have the second annual FCHAR symposium, also to be held in Orlando. Just quickly to go over some of the subcommittee conference call discussions and recommendations. Again, we had 2 sets of conference calls in May and September. And the 4 groups that we're talking about are research education, antiretrovirals and other therapeutics, hard-to-reach populations, and regional networks. The research education subcommittee, we're developing an inventory as an educational tool, and I think this is something that not only the HAPCs, but all the folks on the prevention and patient care planning groups should be familiar with. It's now posted on the FCHAR website. It's also posted on the DOH, Bureau of HIV/AIDS website. I guess the Bureau of HIV/AIDS website is going to be called something else in the near future. We're arranging the inventory by study type and then by institution. Again, we've now got 435 studies. We want to focus on the current and the proposed studies, because I think that's going to be the most useful to you. We're going to be targeting the providers, case managers, and yourselves. The inventory is not so much for patients, but of course they'll have access to it because it'll be on the website. We'll have hyperlinks to greater details about the studies. We're developing educational recruitment brochures as part of the Research Education Subcommittee. And we think that FCHAR can be shown to be a national best practice, a new paradigm, and this will probably help us get some long-term funding. The second subcommittee is the antiretrovirals and other therapeutics. This is also concerned with basic science research. We talked about key pharmaceutical contacts, send selected studies to them. Also talked about one-stop shopping for submitting to the IRB, and we're working with Megan Kennedy, the IRB director, to try and help us do that. We also discussed what to do when participants end or leave a trial, a clinical trial. And we're committed to developing a unique, clever hypothesis for a study to attract unrestricted pharmaceutical funds. The University of Miami is taking the lead in preparing an application for an interagency study that would address that concern. The hard-to-reach populations and specimens subcommittee, addressing biologic specimens that are hard to obtain. In particular, One of the main studies that we think is going to contribute to finding a cure and a vaccine is going to be looking at acute HIV infections. It's very hard to identify those because even though we have an incidence estimate of 5,000 per year, as you can imagine, finding persons in that window period and the eclipse period before the window period, before antibodies develop, is very, very hard to do, hard to document, and hard to do fast enough so that specimens can be obtained. We're also looking at participant enrollment challenges in prevention studies. We identified 27 target populations that were hard to reach and developed a survey. We identified researchers who have had difficulties and those who have had some successes, and we've kind of arranged contacts to share lessons learned. The Regional Network Subcommittee talked about bringing studies to participants, in addition to bringing participants to the studies. Of course, it has a larger pool of patients and behavioral participants. We want to network regionally for efficiencies and grant writing. And we want to develop memorandums of understanding as we go on with the collaborations. And it won't be legally binding, but the memorandums of understanding will foster the collaboration we're looking for. So we're defining boundaries. We say here 3 regions, but we've actually come up with 4. And they would be comprising all 67 counties. Here we're showing the 3 regions, but more recently we've decided to make this into 4 regions. There would be a northern, shown exactly as here. There'd be a north central and a south central, and a southern region. The southern region would be Broward, Dade, and Monroe. The other counties in between will be the southern central regions. The research inventory began compiling the inventory in 2010. We currently post it on the DOH Bureau of AIDS Research and all the website, and also on the FCHAR website. We organize it according to study type, and within each type by institution. It is posted on the FCHAR website now, and eventually we're going to have hyperlinks to detailed information about each study. This is just an organizational chart. On the right-hand side, you see the Consortium for HIV/AIDS Research. And if you want to contact me, this is my new contact information. Michael Rubel can be contacted as far as is listed here. And in closing, I want to say we're referring to ourselves as the consortium. From my point of view, from Michael's point of view, we're referring to it as the consortium. So whether it's tomatoes or tomatoes, it's still one entity. And I'm wondering how many people in this room would pronounce it consortium? Raise your hands. And how many would pronounce it consortium? Come on, it's got to be more than one. Well, if you think that's confusing, right? If you think that's confusing, just look up bi-monthly in a Google definition. The Google definition of bi-monthly is either every other month or twice a month. Go figure. Thank you very much.
Questions?
Joey wants to know when you retired.
No, I actually heard about the park. My question would be, how often will you all provide updates and to whom? Yeah.
That's a good question. What would you suggest?
No, well, I would think if there's some landmark activity or achievement that happened, that you would share that statewide, because if this is a statewide magnitude of participation, it has statewide impact. Then we come back here at least quarterly with some kind of update, however brief.
Well, we'd be happy to come back to this meeting, that's for sure. We're not holding this meeting quarterly.
Right, yeah.
What are we
Twice
doing?
a year. Twice a year, really.
Twice a year? By hand.
Probably, right? It's twice a year, right? For PCPG? Yeah, pretty much.
Well, we'd be happy to come here, for one thing. For another thing, the Executive Advisory Board and the upcoming symposium in January, we could share the minutes from those meetings with you and let you distribute them. And we would do that with the prevention planning group too. Any other questions, comments?
Thank you.
Thank you. Thank you for the opportunity to address.
I think Joe and others asked me to say a few things about some of the things that Joe mentioned as far as an update. I want to bring you up to date on the reorg, which is going to be a lot of I don't knows, and maybe just quickly cover a couple of other hot button issues, and then open it up for questions. So let me tackle some easy updates first. First is, I wanted to mention that to everybody, because you were actually just talking about surveillance. And as many of you know, the prevention cooperative agreement in the United States got turned upside down this year. There was a whole new process where we'll be funded on January 1st, 2012, but the priorities, the funding caused quite a firestorm around the country, and it put Florida in a little bit awkward situation because we were the biggest winners in the United States. We are the biggest winner, no one else. But there were so many states that lost, and they're very upset, and everyone's trying to deal with that. Because here it is October, their new money comes in January, and they're laying people off as we speak. And obviously we're not doing that. So keep in mind that that was a lot of when I walked in your discussion about moving the money to the high incidence areas. Well, we're going to start the whole process over again for surveillance. Now, we hardly ever talk about surveillance money, but surveillance money keeps the people employed, in a sense, around our state to produce all the numbers that we all deal with. And today at noon was one of the first national calls about the new surveillance cooperative agreement. And I suspect that we could be another winner in this area if CDC follows the epidemic, if CDC moves money around the United States. But surveillance has a lot of different pieces in the grant. It's not like prevention. There's core surveillance, incident surveillance, behavioral surveillance, resistance surveillance. They come in little pieces. And so I just put a heads up that until this process works its way out, like prevention did, we won't know the end result. So very quickly, prevention. Many of you have seen the spreadsheet, and it's likely that Florida will be a big winner on January 1st, 2012, barring something that happens in Congress or something that happens with their allocations. And specifically in that cooperative agreement, Miami and Fort Lauderdale will receive increases and are directly funded with a specific number. So Marlene on my staff has spent a lot of time with Miami and Fort Lauderdale, including myself, on making this happen. Paul, and I don't know if Kira's here, but Paul and Paul Moore from Broward and Kira from Dade have taken the lead at the local level. So from an epidemiological standpoint, from an old disease kind of standpoint, I'm actually very excited about this because it might finally give us the amount of resources, or close to the amount of resources, that we can put in two high impact areas, namely Fort Lauderdale and Miami, to bring down those rates. There will be enhanced money to beef up testing, in particular in South Florida. Before I switch to care and treatment, again on the prevention side, just coincidentally, last week, Debbie, CDC held a jurisdictional meeting in Florida. It was held in Orlando, and all the directly funded providers in Florida and the state and some county folks and a bunch of folks met in Orlando to talk about all the prevention grantees that are in the state of Florida. CDC sent down about 6 to 8 people, a lot of people. We had a lot of people, and I got the report this morning actually that it went extremely well. CDC was very complimentary of Florida in their communication and in some of their programs. I think testing always blows CDC kind of out of the water. So I just want to report back on that. And it's some of our providers that were there, as you may know, Care Resource in Miami is the only provider in the state that got the new money for Black MSM. So that was highlighted and talked about a little bit.
Do you foresee any possibility of changes between now and January with other states trying to change the allocation or somehow?
Well, that's the 64 or the $320 million question. Will the states get what's on that spreadsheet? We don't think so. Because CDC will have flexibility in the range. Those smaller states have really, really complained very loudly. And so I think they're going to implement most of it, but I think they're going to leave themselves some room to help a few places that may be losing. I mean, some states are reporting losing 50% of their money by the end of this process. So, I mean, if you're in Iowa, which comes up a lot, and you have $1 million prevention grant, and you're going to end up with $500,000, the people are sitting around this table in their planning process going, what do we do? How do we do high impact prevention in a state like that with so little money? And CDC's really kind of unable to answer that question because they didn't do it with new funds.
And what you just said, they were very clear about the pressure that they're getting from Washington to mirror the care side with the national HIV/AIDS strategy, and that they said it once, they said it, I'll say to Earl because we were both there, I mean, they repeated it over and over, that prevention dollars have to follow the epidemic like the care dollars, and so what that means for the state is what Marlene highlighted, is for the state, you know, if you're in a small county and you've got some prevention dollars, you probably won't get those prevention dollars once this happens again, because it's going to go to the counties with the highest epidemic.
If we got all the money we asked for on both core prevention and the expanded testing, when you ask, again, you get two answers. What is in this bureau? And it's crystal clear. And then you ask, well, what is in this bureau? And they say, we haven't worked that out yet. So, the Division of Disease Control, which we are housed now, is changed dramatically. There is an entire section added of chronic disease that is in another part of the department right now. There is another section added, again, on the paper, of environmental. The entire division of environmental health is eliminated at this point. And pieces of it go off, and pieces come to the new division of disease control and prevention. And the Bureau of Radiation Control, as an example, gets moved to another division in the Department of Health where preparedness is. So you can kind of start to get the picture of the anxiety level. If you're an employee in one of those bureaus and you're going, where do I work? What is my future? And we're not able to give employees a whole lot of straight answers. Now, the plan, as I understand it, is to write a bill that's been written, that Matt Hudson would be the sponsor in the House, and Joe Negron, the sponsor in the Senate, and put in there the structural changes of the new Department of Health. And then they would go at it during the legislative session in January. And knowing how bills work, it's not going to be what we send them, because they can amend it and change it. I mean, it just takes one strike of the pen to move medical quality assurance to DPVR if the chairman is stuck on it. The Department of Health, as of this last session, has been cut by $255 million in general revenue funding statewide, of which HIV is about 4 million plus. It just depends where you are in the country, if you think that's a big number or a small number. If you're in California, they've been cut by about 82 million in AIDS general revenue. And we've been cut by 4 million, so it's a small number.